Good morning, one and all. I am Raven from first year MBA.
I'm Soumya from first year MBA.
Reva Business School is established with a long-term vision to educate and empower the next generation managers and leaders to build sustainable businesses, which will not only enable them in achieving operational excellence but also explore new business models. With a highly trained faculty and enabled management, Reva Business School provides its students a great learning environment that fosters intellectual, social, and ethical development and thus enables them to pursue successful and fulfilling careers. Our practice of conducting distinguished lecture series helps students develop holistically. And today we are going to witness one such lecture, the intersection of economics and healthcare, implications for business and management. The intersection of economics and healthcare is a crucial field of study that examines the economic factors and principles that influence the healthcare sector. It involves analyzing the production, distribution, and consumption of healthcare goods and services, as well as the impact of healthcare policies and regulations on economic outcomes. To enlighten us more, we have with us an eminent personality, Dr. Shamika Ravi.
Dr. Shamika Ravi is an eminent economist and a leading public policy expert from India. She has an extensive background in economics and research. She holds a PhD in economics from the prestigious Columbia University in New York. She has also worked as a postdoctoral fellow at Stanford University Center for International Development. Dr. Shamika has specialized in the fields of health economics, development economics, and applied econometrics. She has held various influential positions in the Indian governments and international organizations. From 2015 to 2019, Dr. Shamika served as a member of the Prime Minister's Economic Advisory Council in India, advising the government on economic and policy matters. During her tenure, she contributed significantly to policy discussions related to agriculture, employment, and health. Dr. Shamika is known for her research on diverse topics such as public health, poverty, education, and labor market. She has published her work in renowned academic journals and has been a frequent speaker at conferences and seminars. Her research focuses on evidence-based policy making, where she utilizes data and analytics to shape policy decisions. Additionally, Dr. Shamika is actively involved in promoting economics and policy debates in India. She associated with several think tanks and research institutions, including the Brookings Institutions, where she serves as a non-resident senior fellow. Through her various roles, Dr. Shamika has been instrumental in shaping the discourse on economic development and public policy in India. We are immensely honored to have you among us. We welcome you, ma'am. I welcome our Honorable Chancellor, Dr. P. Shamraju, who has been a constant pillar of strength to our school. We welcome you, sir. I also welcome all the faculty members, staff, and students.
Now, to felicitate our guest, I request Honorable Chancellor and Dean Dr. Shubha A. to accompany the guest on stage.
Chancellor to speak a few words.
Very good morning to Dr. Shamika Ravi. We are having a series of this type of lectures. Earlier also I told, these are the important events, that is lecture series happening, particularly in RBS. Earlier, as I said, RBS students should be role models, not only in the campus, even when you go out after completing your degree here, there also you should be the torchbearers. At least people should, where did you study? That is what people should question you, that is ask you. That is the performance you have to do in future, whether it is business or somewhere you settle in the companies. That is what. We are not compromising to give you anything you want, particularly this batch, it is from this year. So my expectation from you is a lot. As management students, even whether it is maintaining discipline, performance, your behavior, whether it is body language, everything for that matter, inside the campus also, so other students, we have 16,000 students in the campus, they have to learn. That is my expectation, not only in the campus, even outside. And you should be the role models everywhere throughout your life. I wish you all the best. Make use of these lectures. I think you might have heard in my TV interviews I used to say, education institutions are responsible in building the nation, and any country to develop, Vidya, Vaidya, Vyavasaya. These are the three things which are important, that is education, health and agriculture. Madam is talking about today with education and agriculture. She is the expert in that. That is what I heard when the anchor was telling. I think you have a very great opportunity to listen to her and make use of that. I will listen, anyway you will be recording, I think I require that. Once again, wish you all the best. Thanks, madam, because I have to go there somewhere, that's why I am missing your lecture. Thank you.
For the slides. Okay, okay. So will they be able to change if I say next and so on? Okay, let's make use of available technology. The American system of health financing is fundamentally based on insurance. Right? Health financing is mostly done through insurance. Insurance has some very core problems. Now, I know you are mostly in the first and the second year as well, right? Have you heard of a term called adverse selection and moral hazard? You know what it means? It basically tells you that markets tend to break down. There is something called market failure. Market failure happens when the buyer and the seller don't have the same information. So when you go to a hospital and the hospital asks you, are you insured? And you say, yes, you are insured, then the whole protocol of treatment is different than it is if you're not insured. And the question should be, why should that matter? Well, it matters. Because insurance invariably leads to overutilization of facilities. Because as a patient, if I'm insured, and the doctor tells me, Dr. Ravi, you need to take care of these 18 tests, I'll say, fine. I don't have to pay for it, I'm insured. So I'll say, okay, I'll do all the tests. The doctors are thinking, I need to meet certain bottom lines. I have to do so many surgeries, I need to show certain revenue. So there is also overprescription from the doctor's side. The two together means nobody in the system has any incentive to cut the costs. Do you see? Neither the patient nor the doctor has any core incentive to cut costs if it is insurance-financed healthcare. This is what leads to cost escalation. Now, we do have ways of addressing it. We can say, okay, introduce some co-payment, meaning the patient must pay X%, so you don't want to inflate the bill. But these are small patchwork. Fundamentally, information asymmetry, which is market failure in healthcare, will lead to overutilization of health facilities, which is cost escalation. You will end up spending a lot of money. But that is the core. That is what a market failure is. Now, let me also tell you, in India itself, in India, you know what percentage of our healthcare is private? Anyone? How much of our healthcare is private? It's close to 75%. So 75% of India's healthcare is from the private sector. This is OPD, outpatient, when you go for consulting. 55% for IPD, inpatient, hospitalization based. So India's healthcare also has a lot of private, right? We depend a great deal on private or industry to provide us healthcare, right? Which is why, now if I tell you that, you know, when babies are delivered, what percentage of the deliveries are C-section? You know what is a C-section? Caesarean section is a major surgery. Costs a lot of money. What percentage of deliveries are C-section in public facility, meaning government hospitals? It's 10 to 12%. 10 to 12% of deliveries are complicated and they require a C-section in public facilities. What is that number for private facilities? Somebody here loves 90%. No, very few things in life are really 90%, unless they are your 10th and 12th grades. No, we are not getting into that. That number in India is close to 49%. Almost, think of it, almost 50% of all deliveries in private hospitals today are C-section. And that number is 10 to 12% in government hospital. Kyun? Why should that be? Do you now understand market failure? This is at the core of health economics when we want to come up with policy. We do recognize that, number one, private healthcare is very important for a country like India. Public health infrastructure is not enough. So we have to allow and encourage private healthcare. That is number one. Number two, private care needs certain kinds of regulation. Otherwise, you will have overutilization. In the case of the US, I just told you how you are going to overuse facilities and it leads to cost escalation. But US is a rich country, and even there, health is a very big problem. National elections are contested, lost and won on the back of healthcare. So health financing in India is also a very big concern. Okay, can we go to the first slide, please? You know, India has undergone tremendous change in the last 30 years. So, right before your birth, let me tell you, things were very different. But in the last 30 years, and just go to the subsequent points, please. Just go next. We have become more urban, we have become more literate, we have more toilets. Toilets are very important for healthcare. We have a lot more piped water. We have more and better drinking water. We are definitely less poor because our per capita consumption expenditure, which is a measure of poverty, has been rising. So we are less and less poor. And a lot more insurance has been rolled out through the private sector itself, which means for most of us, but also through the government. You know that the bottom 40% of Indian population has something called Ayushman Bharat. So around 50 crore people have access to publicly financed health insurance scheme. All of these things have profound impact on the health of a household. The fact that you are more literate, the fact that you are more urban. Why does urban-rural matter? Because 75% of our healthcare infrastructure is in urban areas. So in urban areas, the access to care is much more. But urban India is also seeing a massive increase in healthcare burden, meaning they're spending much more on healthcare now. All right, next please. Next, please, just continue, just put all the bullets there. You know, not only are we becoming, therefore, as we become better off or less poor, we are consuming better. But the bigger thing is health seeking itself has changed. We find in the National Sample Survey that more households are reporting being sick. It doesn't mean that more sickness has suddenly happened. No. It means more people are now saying, yes, I am sick, I am going to get care. Earlier, when certain kind of ailments, people never sought care. So these are big changes in the health seeking behavior. 18% increase in urban household sickness. People are just going to hospitals more. All right? 14% increase in females seeking care because there are huge disparities in gender in terms of access to care. In fact, usually for the same ailment, a woman will say, I'm okay. Men are likely to say, I'm not okay, and therefore I need care. Okay? So in women, health seeking has been suppressed for very, many long time. So you are seeing on account of all this development that is happening, more and more women are reporting being sick and taking or availing care. We are seeing a big increase in outpatient department, meaning people are visiting doctor for consultation. But you see the increase in IPD, meaning hospitalization, 42%. This is in the period of the last 10 years. Almost, imagine, 42% in IPD means now many more things people are getting hospitalized than they were getting before. And you know what is one of the biggest change or incentive for hospitalization? The fact that you have insurance. Earlier, most deliveries were also happening either in the homes or they were happening in the neighborhood. Today, we are incentivizing institutional delivery, meaning the mother will get money, the ASHA worker will get money if the delivery of the baby happens in the hospital. For many more care, now people are getting hospitalized. Elective surgeries, etc. have really shot up as well. This is just a nature. This happens in every economy. You are going to seek more care as you become more affluent. Okay? And IPD increase is very significant. Now, as I mentioned before, 75% of our OPD is exclusively private and 55% of the IPD is private, which means private is a very large part of India's healthcare. So this is very important, and this is also important from the policy perspective. Private healthcare is not a bad word. India basically depends on private healthcare for its healthcare needs. So you can't wish it away, and that is also not the right way to think about it. I'm speaking to you as someone who influences policy. Otherwise, people think private healthcare not very nice. Quality is not good. That's not true. Okay? There are concerns of quality, and we will get to that. Next. Yeah. Continue, please. Now, what you are seeing is, as more and more insurance has percolated in the economy, you are seeing more and more hospitalization. It doesn't mean that insurance is necessarily driving people into hospitals. It is telling you that now that you have insurance, you will avail the care, which is a good thing, which is a mark of development. Next. In healthcare, we have something called out-of-pocket health expenditure. You know what it means? It means out of every rupee that is spent on healthcare, what fraction comes from private pocket? This is called out-of-pocket health expenditure. This number is around 40% in China. It's 11% in Thailand. And in India, it used to be around 67%, 10 years back. Today, that number is down to 48%. Do you see now what this kind of massive insurance drive is doing to people's health expenses or people's burden of healthcare on their pockets? It is making it less burdensome. From 67 paisa for every rupee that was coming out of private pocket, now 48 paisa is coming out. All right? Next. Continue, yes. So, growing use of private hospitals for all ailments except childcare. And this is an outcome of policy. Because, you know, almost every country in the world has signed something called the UN Sustainable Development Goals. that these are the main development goals that we want to achieve. And we are signatories, meaning we do want to have it. We want to be able to achieve these targets. And maternal mortality rate is one of the most important, along with infant mortality rate. These are some metrics that we want to improve. India has seen a massive 77% decline in maternal mortality rate. The global decline is 44%. So you are seeing how rapidly India is decreasing one of our main problems, which used to be maternal mortality rates. Okay? Next. This number, this graph is showing you something fascinating. On the x-axis, you have GDP per capita, meaning as poverty is reducing, what is happening to infant mortality across the country? It's falling, it's crashing. See, this is one of my favorite graphs. It is not only true for the southern states, it is true for our poorest states, Bihar, Madhya Pradesh, Rajasthan, Uttar Pradesh. It is true for all states. And the poorest states, you are seeing the bigger the size of the ball, the bigger the population. Do you see how drastically they are all falling? This is on account of economic growth. And therein lies a very important point, that economic growth is not just about rich people. Economic growth translates into better outcomes of development. Because when you become less poor or when you grow richer, you eat better. You drink cleaner water. You have toilets. You have access to water. You have access to healthcare as well. So fewer and fewer babies are going to die. IMR, or infant mortality rate, is therefore one of those core metrics that we watch very closely, because it tells you what is the improvement overall in terms of healthcare in the economy. So as we develop, this is why it's important to understand when we say we need economic growth, we are saying this is what economic growth helps us achieve. It helps us reduce all these various indicators. It improves them drastically. I just told you maternal mortality fell by 77%. The decline in infant mortality is absolutely pervasive. It is happening all across the country. So what you read in the newspapers, economic growth, it's about a few corporates, it's about growth is mostly shown as being a matter for rich people. That is not true at all. Economic growth leads to improvement in quality of life for everyone, right? Because this is what inclusive growth actually means. Next. Now I want to basically ask you a simple question. Where do you think the poorest people in the economy go to get health needs? There is a myth. We often think that the poorest people go to government hospital. And we are a bit better off, so we go to private corporate hospitals, the nice shiny ones. Actually, that's not true at all. It's a myth. If you look at the data, these are all your major states. The blue lines are telling you what proportion of the state's population, the poor population, goes to public hospital, and the orange part is the proportion that goes to private hospital. First of all, do you see that there is a systematic difference across states of India? India is not one market. Whenever you think of Indian labor market, Indian agriculture market, Indian health market and education market, you have vibrant state markets. So you should think of this as 28 vibrant state economies in terms of healthcare. It's telling you that in states like Odisha, Kerala, Jammu Kashmir, Tamil Nadu, Himachal Pradesh, Assam, and that's a motley bunch, no? The poorer, richer, all of them are bunched. Majority, more than 85% of the poor are going to government hospitals. Now you look at the bottom 5. UP, Bihar, Jharkhand, Punjab, Telangana, Haryana. Majority of them go to private hospitals. What is the first thing that strikes you? That amongst those bottom 5 states that I mentioned, you have the poorest 3 and the richest 2. Haryana and Telangana are 2 of your, and Punjab, richer states. UP, Bihar are your poorest states. So it is not true that the poor go to public hospital and the rich go to private. Not true. It's a myth. The data is telling you that when the government hospital works well, if it is of high quality, everybody likes to go to government hospitals. Where it doesn't work well, nobody wants to go there. Everybody would prefer private alternative. So this is telling you, why do I have to study like this, some of these indicators? It's telling me that in the future, Ayushman Bharat, which is a publicly financed health insurance scheme, so it's government funded, but remember, it is money by itself means nothing. What is the care that it will buy? Insurance is just a financial instrument. Health insurance is a mere financial instrument. It is only as good or bad as the actual care that it can buy. So what kind of healthcare infrastructure is there in the state? That's why this is important. This is telling me from the America and the Singapore model example I just gave you that, in the top states where public facilities are actually there, their cost escalation will not happen because government hospitals have no incentive to inflate costs. So Ayushman Bharat, over a long term, is sustainable. But in the bottom states, where it is publicly financed health insurance, but the care is from the private sector, in the next 25, 30 years, we have to worry about cost escalation because costs will escalate. So where are we going to get the money to fund or finance an increasing cost that private sector is going to throw at us? Do you all appreciate this problem? That you have 28 state economies and they are not all alike. And health insurance as an instrument to finance will work in some places. In other places, we have to be worried. We should think of alternatives because it is mostly financing private care. Next. This is to show, again, the same thing that the rich go to private and the poor go to public. It is a myth. And I am able to show that by looking at 4 states of the country. I look at Kerala, Tamil Nadu, Bihar, and UP. Why do I pick up these states? Because if you look at the people going to district hospital, meaning government facility, what is happening in Kerala and Tamil Nadu? Across quintile groups, from the poorest to the richest. You see what the graph is telling you? Different quintile groups in the economy. The poorest and the richest. Almost everybody is going to government hospitals across the economy. What about UP and Bihar? Across quintile groups, nobody is going to government hospitals. So it is not true that the rich are going to private and the poor are going to public. This is not true. What is the difference from the top graph and the bottom graph? The difference is that in the top graph, everybody is going because public facilities are working. So everybody will go there. In the bottom, we know that the public facilities are not working. The quality is very bad. So everybody, rich, poor, everybody prefers to go to private clinics. This, my dear students, is how we define market failure. This is why we say in healthcare, markets break down. So if markets break down, we know that what is the remedy? Government. You need major investment in public facilities. So public health care has to be strengthened because this is what is going to happen. People prefer it. Quality is superior. There is greater trust in the public facility. You know that the doctor is not going to do overutilization. No extra stent will be put, no extra testing will be done. That is where the trust comes from. And that is how you have to understand markets. All right? And that is also how you have to understand policy making and regulation of healthcare has to do with trust. And how do you build that trust over time? Next. Now, in the current setup, and this is why we will get into now the details of what are the management. By the way, many aspects of what I have shown you have deep management implications for governments. They have to manage things differently. But now I'm going to start speaking more about the business side of things. We have major rural-urban inequities. Like I said, 75% of health infrastructure is in urban India. We have very significant male-female inequities. So we actually wrote a paper using more than 2 million data points from All India Institute of Medical Sciences. This is our premium hospital in Delhi. It is the largest public hospital in Asia, AIIMS in Delhi. What do we find? We find that almost 50% of female patients are missing. What does that mean? That forget gynecology and obstetrics. Those are female departments. But heart, trauma, orthopedics, you look at all these other departments of healthcare, 50% females are not there. They should have been there, but they're not in the hospitals. Why? Is it that women are much more healthy and so we don't need care? Is it that insurance is saying, no, women will not be insured? By the way, this is AIIMS. AIIMS is not very expensive. So it is not cost. What is it? Why are women not going to hospitals? Awareness. But tell me, in the same household, the men are going, the women are not going. 50%, do you appreciate that 50%, 47 to be precise, is a very large number? It's not a difference of 3-4%. 47% difference between men and women in accessing care. Why? Is it awareness, or do you want to be a little more clear? Huh? Negligence, yes, it is discrimination. Because the costs are not very different. This is AIIMS. It's practically free. It's very, very cheap for everybody. So now the disparity, and you have to understand why it is a very troubling thing for policymakers. You can make it free, but even then, the women's care is not going to be improved significantly. So some things you have policy instruments. You can impact by policy, pricing, etc. Some other things, the solution lies in the community. The negligence and the discrimination you're saying is in the household, is at the community level. For that, what is the policy lever? What can the government do? You can do awareness campaigns, but eventually that kind of change and that kind of revolution and change in mindset. That's why we said that NSS, we are very happy when more and more women are saying that, yes, I need care. Which means now they can push and get that care. Okay? So there is discrimination. Yes, next. Now, there is another piece of research that came out on health seeking, and this is from microfinance clients. Microfinance are not destitutes. These are not very poor people. Microfinance clients are people who have some business, some small micro business running, and they can take the loan and they use the loan. Amongst this clientele, we saw that when people took loan, health insurance was tied to the loan. By the way, amongst the students, those of you who have taken loan to come and study here, if you read the fine print, there is an element of insurance in your loan. These are tied products. This is how insurance is sold to a large extent. But in the microfinance loans, many microfinance institutions sell credit which is tied to insurance. But then the data is showing you that the women who are borrowers, they are filing claims when they fall sick. But the wives of the male borrowers are never filing claims. Do you see how weird that is? Because the loan covers the whole family. So people are paying the premium. Now this is not government insurance. So this is not publicly financed. People are paying premium. And even there we are seeing that despite paying a premium, while the women, when they are borrowers themselves, they file claim when they fall sick. But when the borrowers are men, the wives are almost never filing claims. The family is insured. That is such a weird situation. But you know what it tells you? It tells you this is the financial literacy that we try to target. That women, when they are borrowers, they are actively engaged in financial decision making. They are taking the loan, they are coming to the bank branch, or they are having these kind of microfinance meetings when the loan officer is actually telling them this is what you do with the loan. This is how you file a claim. That is financial literacy. But when the women are spouses, that knowledge is not getting percolated. That rests with the borrower, who is the husband. So People are paying the premium but not filing claims. That is absolutely weird when we think of from a business opportunity. But that is where financial literacy matters. We need to think of what aspect of financial literacy needs to be imparted and who will pay for it. Okay, that's number 2. Now, the business idea part of a lot of these markets in healthcare and healthcare insurance has to do with understanding how people respond. And I really hope that as a part of your management training, you will be influenced by literature from psychology. We call this behavioral finance. Behavioral finance has to do with all that area in finance which looks beyond the neoclassical view of things, which means that everybody is rational and everybody is making rational decisions all the time. We know that is not true. Why do I say that? Let me give you an example. I'm sure we have gyms on the facility. We have gyms here in the university? Great. How many of you go to the gyms? Okay, this is like 2 people. Listen, you have great facility, please avail it. This is that part of your life when you do have the luxury to do these kind of things. When you graduate and you go out and you actually work and you get married and you have kids, you're going to be tied up. So self-care will come last. So please, discipline yourself to use those facilities. Now, why am I talking about gym? You know how gym membership is priced? And I'm coming to behavioral finance. Gym membership is not priced as a fixed, it's not priced as you pay as you go. That today you walk into the gym, you use the facility, you pay and you leave. That's not how it works. It usually works as a lump sum membership. That will you pay 50,000 for the membership for the year? Some lump sum, significant amount of fee. Why is pricing done like that? Why is pricing done like that? Because if I ask you a question, is it important to go and work out and do exercise every day? All of you will say, yes. Then I ask you, when was the last time you went and exercised? They'll say, well, not today, but we will do from next semester. So you know when gym membership rises maximum globally? In the first week of January. When you make New Year resolutions. And you say, this year, pakka, I will lose 5 kilos and I'll become strong and I'll run 10 kilometers. This is behavioral finance. The fact that you are not rational. We are not rational people. It's almost like we are playing games with ourselves. That me today is negotiating with me tomorrow. I know what is good for me, but I'm not able to do it. These are self-control problems, right? And behavioral finance, therefore, has to do with the fact that if you recognize that you're not rational all the time, that you do have self-control problem, if you understand this, then you can design financial instruments to match these kind of needs. That is why gym membership is a lump sum payment. It's not pay as you go. Because when you pay 50,000 for membership, you'll say, Abba, I need to avail it because I paid so much money. Do you see what you're doing? This is why people invest money in fixed deposits. And they tie their own hands. Because I don't want to use the money and I want to force myself not to use the money. So a lot of product design in financial markets have to do with behavioral finance, and health insurance also ties up with some of these things. Can we think of health savings? And by the way, countries like Singapore have it. We have had some successful experiments in India. That one of the reasons people are not able to match their savings, that I want to save this much, because I need it for health care. When I fall sick, I need my money. But one of the reasons people are not able to match their healthcare needs or the savings is because of health shocks. So do you understand why health is very closely linked with product design and pricing? We should be able to design pricing and design products to match people's needs. Healthcare lends itself to a lot of innovation in product design. Yes, next. Now I want to tell you that usually when you think of Indian market, you think of a very large national market. A lot of our public debates are at a national level. But at a national, India is too large to have national statistics make much sense. Just look at the leading causes of death. I'm just trying to sensitize you to the fact that not only is the public-private nature of our health market different, but the causes of death, the main diseases, the causes of mortality are very different in different states and different for men and women. Look at all India. All India, the biggest cause of mortality for men is cardiovascular diseases, and for women also it is cardiovascular. The second most important is a category called ill-defined. Now I want to introduce you to the whole idea of artificial intelligence, data analytics, machine learning, etc. The quality of data in healthcare is a big problem for us. Ill-defined means when a death has happened, ideally you should have a cause of death. But the data that we have, even in our best hospitals, your second largest category is ill-defined, meaning you really can't tell from the data. Now, are we bad at entering data? No. We are some of the best people for entering data. The problem is that this data is getting entered either by the doctors who are very busy and their time is very precious. They should not be wasting time entering data, number one. Number two, the nurses, a good nurse is often better than the doctor. Even nurses, we are very scarce. So even nurses should not be spending time entering data. That's why now we are creating an entire cadre of health IT workers. And health IT is a very specialized field of IT. You know, you have ICD-10 codes. You need to train people in entering data, which is very specialized. Okay? So that this kind of a problem of ill-defined, we are not grappling with this. It's only high quality data that allows us to come up with innovations, AI, etc. solutions. That we can actually use data to implement certain things. Respiratory diseases are the second largest, the third largest. Now, look at UP. In UP, leading cause of death for men, cardiovascular. For women, ill-defined is there, but what is the next? Diarrheal deaths. Diarrheal death. We should be able to handle this with water. And the ORS. No, water with some salt and some sugar. Do you appreciate the problem of a state like UP, which is one of our least developed states? The leading cause of death for women is diarrheal disease. This can be handled with clean water. Please appreciate the problem. This doesn't need super specialists. So what is the public health intervention therefore? Do we need super specialists? Do we need more beds? Yes, we need those things, but the leading cause of death is not having clean water. Okay? Now look at Uttarakhand. Uttarakhand, when you think, you are thinking, oh, Himalayas, clean air. The leading cause of death for women is respiratory diseases. Why is that? Why are women dying the most out of respiratory diseases in an otherwise Himalayan state with clean air? Indoor pollution. Indoor pollution is one of the leading causes of death for women. Now, do you understand why the LPG scheme is such an important scheme? Because clean cooking fuel, it is not just for the sake of, larger political and electoral needs. It's a public health need. You need it. Then if you think of, look at Uttarakhand, the third leading cause for men is TB, tuberculosis. TB is very closely linked with development. If you have clean, non-cleanliness, filth is very closely tied with TB. And poverty. Poverty is very closely tied with TB. Now for Kerala, cardiovascular diseases and respiratory diseases. So Kerala needs very different intervention from the public health than Uttarakhand and UP. So your policies, therefore, cannot be national level policies anymore. You have to go into what we call precision policy making. States of India are also very large, 220 million people in Uttar Pradesh. Imagine it's a large country by itself. So what we need is now precision policy making at a district level. The average size of an Indian district is 2.5 million people. That's like a European nation. So please appreciate the fact that healthcare, both from the private as well as from the public side, needs a lot more now precise interventions. So business opportunities are also, you should think of them as very precise. Study districts, not even states. Next. So we need to look at Ayushman Bharat because it's a major step towards universal health coverage. Right? We need to focus much more on primary care. Once a person has entered the hospital, it is already too late. So you need to be able to do a lot of filtering at the primary care itself. When you have fever, we should not be going to super specialty hospital when we have fever, but that's exactly what we do. Why? Because the primary healthcare centers are not working in most places. So we end up going to hospitals. And that is where the costs keep escalating. So early intervention, early gatekeeping is one of the hallmarks of a good public health system. Then we have these disparities. Then, of course, a large part of it has to do with we also have to build the government capacity to be able to regulate private care. So when I told you that 49% of deliveries are C-section, these are not bad doctors. These are not evil people. Please appreciate market failure is on account of how the incentives are structured. Okay, it's about the contracting. Next. Yeah. Now I want to make you appreciate the fact that what is happening globally is that the richest countries in the world are aging and aging very fast. And I'm not just talking about the G7, I'm talking about OECD as a whole. So the richest countries are aging. What happens with aging? Your cost of care is going to keep rising. By the way, no country has managed to actually reduce their healthcare expenditure. Healthcare costs will continue to rise. Now, as the global economy is aging and the healthcare costs are rising, they are all looking for opportunities to cut these costs, to reduce these costs. That is the opportunity India has for the next 100 years. Because demography is a very powerful economic force. Aging global population means the richest economies in the world are going to look at countries like India. Number one, medical tourism. Do you know it's the fastest growing sector in the country? It is one of the fastest growing sector. Number two, India is called the pharmacy to the world because almost 70% of global vaccines, and this is even beyond COVID, 70% of global vaccines are made here. This is the country where generics, almost majority of generics drugs are produced here, manufactured here. Medical equipments. Medical equipments is again one of the fastest growing sectors. All kinds of equipment, right, from the low end to the high end, they can be produced. Now the extremely high, that which requires R&D, etc., we are not there yet because our R&D, we are not at the cutting edge. But a lot of them are surgical gloves, injections, etc., right? Including things like oximeters. We are producing in very, very large numbers. Human resources. India is called the HR factory of the world. Now, as a public health person, I worry about it because it means that our doctors and nurses are going abroad. We have very few that are left behind. And that has a policy intervention. We need to make it more lucrative for them to stay back, number one. But number two, they are also an important source of economic growth. When they migrate, when they go out, they are also remitting a lot of money back home. They're also sending technology, know-how. When they come back and work, they're training people. So there is a lot of technology transfer that is happening through the HR as well. So human resources is increasingly becoming one of our strategic assets. Our large population, therefore, when we say demographic dividend, that's what it means. That India supplying doctors and nurses to the world is seen as one of the ways in which these rich countries are also managing to lower their health cost. Therefore, for us strategically, we have to train more and more doctors, nurses, health IT. Health IT is very specialized. Artificial intelligence. Do you know now you can deploy, because we have so much data. One of the core advantages of economies like India and China is that we are such large economies and our data is so large and vast that data in healthcare becomes a strategic asset in itself. You can deploy these large data to come up with better AI solutions. And in case, by the way, we are doing this, not just in simple things like scheduling. How should you schedule? When you look at the data, it tells you people come late on Monday mornings. People come on time on other days. Afternoons are low time. So now scheduling can become far more nuanced. But scheduling is simple. It's a mechanical exercise. You can go into far more nuanced aspect of healthcare. Hospital-induced infections. We can try and see which are the OTs there, infections are more likely. What are the different kinds of ailments which can reduce average length of stay, so we can actually plan accordingly. So operations becomes more efficient when we deploy this kind of large data for better care and faster, cheaper care. Okay? So AI needs data. Data is very, very strategic. Next. So the way I basically structured the talk today was first in terms of the public side of things, which is needed, and COVID basically made it very clear that when you have a communicable disease or you have an infectious disease, then private healthcare has limited solutions. Okay? Private hospitals, just the nature of infectious diseases are such that infectious diseases are largely within the purview of government facilities, because you have externalities. When one person is infected, you're not just treating one person, the chance of expanding that infection is much higher, so it is a public good. So externalities, the minute you hear the term externality, you should understand you are saying that markets will fail. So private care is limited, you need government facilities. So you should now understand market failure, you should understand from the private side, what is the growth opportunity for India? Healthcare is no longer only about public health. Health should be seen as an engine of growth. So what IT sector did for India in the last 40 years, healthcare has the potential to do this for India for the next 100 years on account of global demography. The demographic changes that are happening to the rich countries means for India it is a massive, massive growth opportunity. So don't just think of India health market as a public health, think of it as an engine of growth. Next. Now, in terms of management of the pandemic and the global poverty targets, I want to sensitize you to something that, you know, because of the pandemic, all economies have undergone a shock. But this graph is telling you which are the countries which are falling behind in the SDGs, and that too SDG 1, which is poverty, to eradicate poverty. The countries in red are going to miss their poverty targets. Do you realize that there are many countries which are much richer than us in this target? Do you see Brazil? Brazil is at least 4.5, 5 times richer than us. Do you see South Africa? South Africa is again 5 times richer than us. These are richer countries, but their poverty targets, they are going to miss it, the SDG targets. Largely on account of the fact, and by the way, this is data from January 2023. I'm sure if it is updated next year, you will see Pakistan also go into the red, and parts of Sri Lanka will also go into red. Please appreciate, the pandemic has dealt such a heavy blow to global economies that many, many emerging market economies or developing economies are now in complete turmoil. They're very fragile. And you are seeing this. Repeatedly, countries going to the IMF for support, extending their credit line, etc., because of the pandemic. These are specialized economies, economies that are heavily reliant on tourism. That's the case that happened with Sri Lanka. Economies like Pakistan, etc., huge amount of instability internally. So these economies, and largely again perpetuated, weak institutions make everything worse, but the pandemic has been a large problem. India therefore does again stand out, that we are the poorest country in the G20. but pragmatic management, basic fundamentals are strong. And that just means, and with decent inflation control, with not going overboard in spending money like you saw many of the OECD countries do. They pumped in so much money to basically as a fiscal stimulus against the pandemic that now they're all battling very high inflation. And then the war in Ukraine has only made things worse because the oil supplies have been affected very badly. Then the trade war between US and China has meant great instability from there as well. But many of these things are also opportunities for us. So the US-China trade war and many more corporations wanting to move their supply chains from China, which is by the way called China Plus One strategy. China Plus strategy means large multinational corporations are now looking to move their supply chain away from China. India sees that as an opportunity. Okay? India sees that as an opportunity. Again, basically improving and accelerating the recovery from the pandemic and higher growth. Next. This is the last slide of the talk, and then I'm happy to take questions. This slide basically introduces you to a concept in corporate finance. We used to call this, by the way, this whole concept is called narrative economics. What is narrative economics? You know, in corporate finance, this is well recorded that firms plant stories. And planting of the story has a direct bearing on the stock value, the stock price. So if you look at stock markets, stories influence stock markets, okay, and valuation, etc. What used to be limited to corporate finance is now increasingly getting deployed in international relations as well. This graph is from publicly available data from Google called GDELT. And you know what this data is? It's all global media, meaning across all the countries of the world that have Google. So this includes data from more than 100 languages across the world. This measures something called tone of the media. How are you covering a particular country? Are you covering it in positive news or negative news? How positive, how negative? How are you able to do that? You deploy something called natural language processing. You string words together to see whether it is a positive news, very positive news, negative, very negative, etc. So you can give values. As you can see, here you have 0, everything below you can go down to -4, it goes all the way to +8 as well. This is at the beginning of COVID. So this is around January. It starts around March, January to March of 2020. Look how global media is covering these 5 major economies of the world, which are China, Sweden, India, US, and Germany. Why am I looking at these 5 countries? Because I want to compare how is global media covering India, which is a large federal democracy, and we are very noisy. Similarly, US, large federal democracy, very noisy. But relatively smaller, more homogeneous democracies like Sweden and Germany. And then you want to look at a country like China. In the beginning, everybody is getting negative coverage, right? And that is normal, because the whole job of media is to cover problems. So media coverage is meant to be negative. That is why we call it. It's a very important part of democracy to have independent and strong media. But what happens within 6 months of the pandemic, of the outbreak? Within 6 months of the COVID outbreak, see what is happening to the global media coverage of all other democracies versus China. Do you see these democracies continue to receive negative coverage? They're all negative, no? By the way, that massive bottom purple line for the US is Donald Trump's re-election. This is around the time when the campaign was kicked off. So very noisy, negative, global coverage. What is happening to coverage of China? It's actually becoming positive. So you start asking, you start wondering, this is not a random trend. There is a campaign from Beijing to actually influence global narratives. So what you know about COVID management is not just the masks and the vaccines and the, whatever else that countries did for themselves. There is something over and beyond the fundamentals of management the way you understand it. There is something called narrative economics which is at play. It used to be confined to corporate finance earlier, that you planted stories and you affected your stock price. You planted good stories, or sometimes you planted bad stories about your competitors. This is now happening at a global level in the form of managing narratives through influencing global media. So this is not Chinese media. Chinese media, most of it is not even on Google. So this is Google data set. I'm saying, why is Ecuador covering China positively? Why is Argentina covering China positively? Why is New Zealand covering China positively? Why is India covering China positively? Because global coverage of China has, in terms of COVID and its aftermath, it's become positive. So please appreciate that not just limited to healthcare. This is going to be a very important part of every sector of the economy. You are going to see stories planted. And as India becomes more and more developed, you are going to face competition. Your competitors are no longer only domestic competitors. You will have competitors when you sit at the table of WTO and you are doing trade negotiations. And when you are negotiating and what is coming on the table is human rights violations by India, this is what you are working against. You have to be able to negotiate, and the terms of negotiation are no longer the way we think of business. Businesses work very closely with governments now. And when you're trying vaccine nationalism, if you remember, the largest vaccine manufacturers were working in tandem with their nations and their governments to negotiate and design and basically attract market shares, global market shares. So you saw a lot of stories. Stories went up against one vaccine, another vaccine. Countries were paying very different prices for the same vaccine. So it depends on how you negotiate. So narrative economics is now going to be a part of every sector of the economy, particularly for rapidly growing major economies. So we will have to fight this kind of a thing. And the only way to contest narrative battles in business is you have your own narratives. You need your data. You need to tell your own stories. Nobody else is going to do that for you. Okay? So business, data, and increasingly governments, and of course the larger society. This is what this whole global, when you do courses in government, society, and business, this is what it is. And some of the richest countries have done this beautifully. They've been doing this for 100 years now. For us, these are new things. We are just learning. So for us, diplomacy is now becoming increasingly about economy. Okay? Increasingly. And healthcare is not immune to this. Healthcare is very, very much, because strategically healthcare is going to become bigger and bigger for us. We are big suppliers of medicines. Quality is a concern. We are, in fact, now battling that, meaning there is a real concern in terms of quality and actual regulation. But beyond the actual problem, there is also a narrative battle that Indian pharmaceutical, Indian medical sector, healthcare sector, that you will have to battle. Okay? All right, I want to end with that. Thank you very much for your patience. Happy to take questions if you have time. Hi, how do you want to do it? Will the questions come? Okay.
Now we shall start with the question and answer session.
That's an excellent question, Diksha. Thank you very much. We are always only talking about India as a young country. Yes, our median age is 28, but we have more than 120 million people above the age of 60. So it's a very large number. which means we have to worry about geriatric care. We have to worry about old age. But the medical part of it, Diksha, is a small problem. We will create facilities. Old age facilities are anyway a large part of the increasing, it's an expanding market segment. Old age homes are also getting created as government facilities now. But that is not the big problem. The big problem is that you know what the COVID pandemic has shown us? That in the richest parts of the world, historically we have never seen such large number of people die alone without family. We call them the kinless elderly. Do you see what I'm getting to? I'm trying to tell you, we want to avoid that kind of a situation. So the healthcare part of it is straightforward. The larger part is what do we do about the family structure? How do we make sure that rapid urbanization, rapid nuclearization is not going to basically break down the family structure? Okay, so that is a much larger problem. And no, I don't have a solution. I mean, I'm struggling as much as the rest of you. So we have to, over time, think of what are going to be the solutions. And can institutions replace the family? Meaning old age home, etc. So yes, I think as a market segment, it will continue to increase, Diksha. But the last I checked, it could be a definitional issue. We had 3 geriatrics in the country registered as geriatrics for 120 million, 3. But clearly, I think people not specializing in, right? These are doctors who are trained in general medicine, etc. So yes, I think that market segment is growing, but family structure, I think, is at the heart of a lot of the solutions.
Good morning, good afternoon, ma'am. I'm Dikshant from first year MBA. Ma'am, what I think about is, like, as you said, more about the economics of the healthcare management and sector. But what about the education part of the healthcare segments, like the colleges and the doctors that are they're like pursuing the medical right now, medical courses, like their outlook towards the patients and like I have a friend who is studying MBBS. He like in his batch the students are like we don't want to go to the like rural areas to work. And then, like, their outlook on that kind of thing is it's very stressful work, and people don't understand what we want to say and do, and those kind of problems that which they face. So, like, about that thing in an economic manner, what could like we do?
See, that is Dikshant, right? It's, you know that now part of policy mandates that after you do your graduation, you necessarily mandatorily spend 1 year, sometimes it is 2 years, depending on the state. That's a policy. And states are coming out with these kind of policies to force doctors, fresh graduates, to go and spend time in the rural areas, right? Because the market failure is there. Left to yourself, if I ask you guys, how many of you would go and work in a village? I'm glad. There is one hand. 2. Who wants to go back to rural areas? Most of us have just come out of the rural areas in 1 generation. So it's completely understandable. The point is, how do you solve that problem? Partly, yes, if it's a market failure, government has to respond. So you make it mandatory to spend 1 year, 2 years, etc. The other alternatives, which some states are trying, is there is a premium in the salary structure itself, that if you serve in rural areas, you get 25-30% more, right? But those are, you know, these are different kinds of HR policies which are getting experimented with, and some of them successfully also. Increasingly, telemedicine. Increasingly, by the way, we have primary health centers outside of Lucknow which are linked with doctors in Telangana for diagnosis. So technology makes many things available and many things possible. That's another. But in terms of the other issue, if you have been keeping up with the latest research, is an excellent paper came out just 10 days back. That, you know, Chat GPT has cleared MBBS programs in many parts of the world, I think including here. Don't get shocked. You have to be pragmatic about it. The second is, which is even more compelling evidence, which is telling you that these AI applications are actually far better at diagnosis than the actual doctors, and they are much more empathetic. What do I mean by that? When they actually did a survey of the patients, and these are randomized controlled trials, the patients basically said, the ones who said that yes, my doctor was very empathetic, they actually happened to be AIs. So we are having to rethink many things. How much time a doctor is spending with the patient, how empathetic you are, what is the quality of the care. Technology is going to open up a world of solutions in healthcare also. There will also be problems. And part of regulation is to preempt it and try and minimize it. But I think the solutions and the positive is much, much more. And so a lot of the iniquities in terms of HR availability, rural, etc., I think technology will become our savior at the end. But also, by the way, there are well-meaning youngsters, increasingly a lot of health tech, a lot of new startups are in making affordable healthcare available, in remote parts of the country. So there is a lot that is getting experimented to solve this bridge, this gap.
Does anyone have?
Hello, good afternoon, ma. My name is Kirtan. I'm doing MBA in Finance and Marketing specialization. So I get to know that one catchword in your presentation that financial literacy and awareness affect on health-seeking behavior. If it is important, how can we improve our financial literacy, which is going to affect on our behavior on health-seeking, ma'am?
So financial literacy has to do with the fact that how well do you manage your financial affairs, number one. Number two, but the kind of new product innovation design that is required to actually incentivize or compel people to save. A lot of Indian savings, a large part of it is in the form of illiquid assets, jewelry, non-immovable assets, real estate, etc. Okay? Leads to better and more utilization and seeking care. Okay? So a lot of it has to do in the form of campaigns. You know that awareness has also been in the form of, RBI has been doing a lot of, for the last almost 25 years, since Usha Thorat's time, great amount of thinking on how to expand financial literacy. What is financial literacy? In fact, when I was teaching in one of the premium business schools, I asked my MBA students that they said, what is financial literacy? I said, let me just show you through an example. And I gave them 4 examples to say which of these loans is cheapest. It's a 1,000 rupee loan and you show the interest rate in different forms. There's a flat balance interest rate, there's a declining balance interest rate, and then there is an effective interest rate, an annualized one. Now you guys are MBAs and you're all warriors on the Excel files. But even for you, it is not so easy to think of interest rate when written differently. How do you compare? So why do you expect poor people to be able to have such degrees of sophistication, right? So financial literacy has to do with a lot of these things. Also fine prints and fraud. Many people and Ponzi schemes. Year after year, we hear about, remember the Sharada chit fund that came out of Calcutta? First of all, it is not a chit fund. Chit fund is a very well-regulated entity in India. These are ROSCAs, Rotating Savings Credit Associations. 1982 Act, Chit Fund Act, means chit funds are very well-regulated entities in India. Sharda was not chit fund, it is called chit fund. I'm surprised why the Chit Fund Association didn't sue them. It's a Ponzi scheme. People save and they invest in these Ponzi schemes. So a lot of financial awareness, SEBI and all are struggling with these kind of things. How do you make people aware that this is a Ponzi scheme? Don't put your money there, right? So a lot of it has to do with that, and health is linked with it.
Ma'am, to continuation to the same question, insurance is one of the part of financial literacy. If insurance awareness is going to be in very more in this generation, it also may leads to market mislead, as you said in US. So how can we manage, or what is the alternate solution we have for this?
There are two ways to look at it. One is the market itself throws up some solutions. There are concepts of deductibles and co-payments, okay, where the person who is insured has to pay, or the beneficiary has to pay some fraction, okay. Deductible is when the insurance kicks in only after a certain minimum. But there are also solutions beyond insurance. We have to think of health savings. We have to think, Singapore actually gives some very innovative solutions. So insurance is not the only way to finance healthcare. Okay, think of alternatives.
Finish it, Uma.